Everyone, thank you, Alex. It's an absolute pleasure to be here to present. I've been working with the Institute for 13 years, I calculated, and over that time, I'm so pleased to be associated with this wonderful organisation who really push the boundaries with their scientific progress and their research, and to have things like this as well is just amazing. So, thank you. I got the introductory lecture, so if you've not woken up yet, is this working? No, it's the other one, is it? Hang on. It's this one. My audio didn't work. Oh well, anyway, you were going to hear some thunder and lightning, but I'm quite sure you've had enough coffee to wake up this morning. As Alex says, I work at the Portland Hospital for Women and Children in London. I'm a consultant gynecologist and subspecialist in reproductive medicine and surgery, and I have a special interest in fertility preservation. And I got the difficult talk for the gynecologist. I'm going to discuss fertility and infertility rates in Europe. Then we're going to spend a little bit of time on adult cancer in the reproductive age groups, and then have a word about childhood cancers. So, Parenthood trends in Europe. I'm just going to, this pointer's working? This one? It's this one. Okay. Oh, I get a big white blob. Right, okay. The birth rate, the number of children born in Europe has decreased since the 1960s. And there's this gradual decline. Seems to be setting out a little bit, but we're now at the point where fecundity drop, the fecundity drop is such that there's an average of 1.59 live births per woman in the EU at the moment in 2017. This is according to the Eurostat data. And to renew the population, you really need a total fertility rate of 2.1 per head of the population per woman. And so you depend on immigration to stabilize population levels in Europe, or we do at the moment. And reality means that we're dealing gradually with an aging population with less workforce availability with younger people, unless we do something about it and encourage people to have more children. Also, we are delaying childhood. So the mean age of having first child throughout Europe is 30.7. If you look at what we were doing 20 years ago, or looking at 2001 data, you'll see that most women were starting to have their children at around about 25 to 29, and there was a tail off towards women in their 40s. We've got a little bit of a skew in the data now, because of us, I think, because we're quite good with fertility treatment. So this reflects obviously spontaneous and assisted pregnancies, but you can see that now the mean age at first delivery is a whopping 30 to 34 years, which as a fertility consultant worries me greatly. But we do come to the rescue in the second half of the graph, I think, because there's a really significant relative increase in the over 40 pregnancy rate that is certainly not because of spontaneous pregnancies. Looking at this graph, everybody can look for their own country. No, most people are Spanish, but in terms of best fertility and best fecundity, France and Sweden come out top. Because the French and the Swedish have their children younger and they have more children in general. The lower quadrant here reflects delayed parenthood and having decreased number of children, and Spain is in the lowest of the point of the graph, because it seems that in Spain there is a trend towards delaying childbirth even more and not going on to have more children. So the problem of leaving childbirth until you're older, you have more money, your career is more established, you've met, you hope, the right bloke, is that not only does age present an issue, as we know, in relation to female fertility predominantly, but also male if they're over 50. But there's an increase in acquired causes of infertility as we age due to lifestyle factors and other diseases such as pelvic infection, fibroids, endometriosis, immune disease, ovulation disorders, and in the men as well, things like varicocele and erectile dysfunction can be an issue. But we have a growing group of people who also have had cancer. Or have had chemotherapy or radiotherapy for non-malignant conditions that has a huge insult on the ovaries or the testicles or the uterus in some circumstances. And we're having to deal with more and more people who are in that category these days because of the delay in parenthood as well as a rise in cancer rates. So let's talk a little bit more about cancer. This is I know it's a busy slide, but these are the European data for cancer types in women and men of all ages. As you can see, breast is the predominant cancer. In men, it's prostate cancer, although that applies more to older men who are probably not going to be trying for children. But bowel cancer and lung cancer are all up there as very significant. I looked at the Office of National Statistics data for the UK. The latest data that we have is the 2017 Cancer Registry data. So these are new cancers in the UK in 2017. As expected, there's a huge number of breast cancer cases. But what surprised me was the number of cervical cancer cases in a country that supposedly has a good cervical screening program. And again, the number of ovary cases surprised me. But we've got the bowel cancers, and altogether the hematological malignancies account for a very significant proportion of problems as well. And this is just for women aged between 15 and 45. I am going to pick breast cancer because it's the most common cancer and talk about that a little bit more as one of the adult cancers that we're more likely to be presented with as a fertility consultant. It is the most common cancer. Incidence is rising, but thankfully survival is also rising. And just as an add-on, their increased age at first pregnancy is an independent risk factor for breast cancer. So the combination of delayed parenthood is as a culmination of effects here. I compared the UK to Spain. Spain is on the lower incidence rate for breast cancer in Europe. UK is on the higher side of the incidence rates. So in 2015, we had 55,000 cases. Spain had 27,000, just over. In the group that were less than 45 years old, between 2013 and 2015, there were 10%. And in Spain, only 1.9%. And that reflects the fact that it is a disease that has a lower incidence here, and the incidence tends to rise with age. So the predominant number of cases, I may be adjusted on this by my oncology colleagues, but I think they occur mostly post-menopause. In the last 10 years, there has been a rise, but the 5-year survival rate is fairly good. So a lot of these women who are younger may well go on to decide to have family. Fertility after breast cancer depends on a number of factors. The big one, as Alex referred to in his discussion about the lady of 48, wanting to get pregnant, was the age at diagnosis. So of course, with age, a woman's fertility drops significantly. But we also have to remember that tumours that present in younger women tend to be more aggressive. And so they may need more chemotherapy and more gonadotoxic treatment. So it's not just the age that you have to consider in terms of trying to predict what's going to happen to this lady when she hopefully survives her cancer. The AMH level, I'm sure you all know, is it's a marker in the blood for ovarian reserve. So it gives us an idea about what a lady starts off with, which is important in trying to predict where she might be at the end of her treatment. It depends what chemotherapy is used. The platinum agents are particularly nasty, as are the alkylating agents. It depends how many doses of chemotherapy they need, whether they need repeated doses or courses, and whether they get GnRH analogues. I think it's the Israeli group that have done the most work on the degree of ovarian function suppression provided by the concomitant use of something like Zoladex through a woman's chemotherapy. And so it's standard, certainly in the UK, for women with bowel cancer, with breast cancer, and I think the hematological cancers as well, to have Zoladex the whole way through the chemotherapy. And some oncologists will extend that for over a year post-chemotherapy as well. It depends whether the lady has the BRCA gene. The BRCA gene is responsible for 5 to 10% of breast cancers. It's associated in itself with a lower AMH and an earlier menopause. And Kutluk Oktay, who's done the most work on this in Cornell in New York, has done studies, and any woman with the BRCA gene who presents for egg freezing, for example, usually gets a lower number of eggs and a lower pregnancy rate. That's not completely explainable. But the other element of the BRCA gene, of course, is that you can do PGD on these ladies if you're doing fertility treatment to exclude the BRCA-affected embryos before you replace them. They are a high-risk group, so 26% will develop a contralateral carcinoma within 10 years. There is a large percentage of the BRCAs who are not estrogen receptor and progesterone receptor positive, so they tend to not need tamoxifen, but you have to consider these other factors as well if you're considering a pregnancy. Then coming on to the estrogen and progesterone receptor positive tumours, now it's standard practice for ladies in that situation to be on tamoxifen or letrozole, some kind of aromatase inhibitor, for up to 10 years. And the oncologists, certainly that I work with, are very reluctant to consider pregnancy unless they've been on tamoxifen for at least 2 years. But there is this concept of the tamoxifen holiday. It sounds like a very jolly thing. And the patients really look forward to it if they're having a tamoxifen holiday. In that period of time that the oncologist will say, right, I'll give you this amount of time off tamoxifen, and that's all you're getting to achieve a pregnancy. Time to pregnancy counts for a lot more than any potential risks of gonadotrophin stimulation. I'm sure we'll hear about this later, but we have regimes where we can use letrozole to lower the peak estrogen, and I'm sure you probably know all about that. But it means that if someone has a tamoxifen holiday and they have a reasonable AMH, I will move very quickly. I'll let them try for pregnancy for a little while, but with a very early recourse to IVF. And of course, they may be in the situation where they have eggs or embryos frozen already. That's a completely different thing. But we would move towards that depending on what their recovery AMH is like. But women who do conceive after breast cancer, having had chemotherapy, we now know, when we've quite good data, that the children are not any more likely to be affected by congenital abnormalities. And I think that's really important, because there's certainly a perception that if these eggs have been exposed to chemotherapy, that they may not be safe. It may not be safe for them to try for spontaneous pregnancy, but in fact, that's not the case. Pregnancy after breast cancer may be protective against recurrence. There are large retrospective studies that look and suggest this, although I don't think we can say for sure that that's the case, and it probably varies between cases. But I know we're going to hear about this later. There is an increased pregnancy risk in women who have had breast cancer. There is an increase in preterm delivery, small for gestational age babies and low birth weight, and there is double the risk of any pregnancy complications if chemotherapy has been used or if pregnancy is attempted within 2 years of diagnosis. So let's talk about childhood cancer. Childhood cancer affects 1 in 20 children. In the UK, in 2013 to 2015, there were 1,821 cases. In Spain, 1,500 cases. The median age of presentation is 4 to 5 years. The majority of cases arise before the age of 4, actually. There's been a 13% increase in the UK in diagnosis and treatment since the 1990s. Thankfully, our survival rate has also increased significantly, so that after 5 years, on our latest data that we have an 82% survival rate. What we need to think about longer term for these children who become adults is that most survivors will have at least one chronic condition by the age of 40 as a result of their cancer treatment. And that may be a cardiac thing or a respiratory thing. And what long-term survivors really want to know is, first of all, would they be able to become pregnant? Are there risks because of the pregnancy for them or the child? And will their children get cancer? We do know that the children of cancer survivors, unless it's an inherited form of cancer, are no more likely to have cancer themselves. So what cancers are predominant in childhood? Leukemia is the highest one, followed by the CNS and brain tumours, with retinoblastomas, bone cancers, Wilms tumours, sarcomas, retinoblastomas, lymphomas, and then an assorted group of others. This is a slide taken from the Edinburgh group, who've worked a lot on trying to identify the children who are likely to benefit from fertility preservation. And they have put together something called the Edinburgh criteria, and this is part of the basis of the Edinburgh criteria, which looks at the potential toxicity of any particular treatment for any particular tumour. So in the low risk category, there are few. The vast majority come into the medium are the high risk categories, but soft tissue sarcoma stage 1s or early stage Hodgkin's or Wilms tumour or ALL, acute lymphoblastic leukemia, are in the low grade. But the chemotherapy and the radiotherapy required to treat medium or high risk cases is significantly gonadottoxic. And of course, you have to consider that it's not just the ovaries or the testicles that you need to think about. In the woman, you also need to think about the uterus, and you need to think about the pituitary gland. The more highly toxic chemotherapy agents would be alkylating agents that are standard for, I think, leukemia and Hodgkin's, and the MOP regime. In radiotherapy, a dose to the testicles of over 1.2 gray will cause permanent azoospermia. The Leydig cells seem to be a little bit more resistant. So if a prepubertal boy has radiotherapy, he may maintain enough testosterone to push him through puberty, but he may be azoospermic afterwards. So don't assume that because they've gone through puberty that their sperm production is okay. Total body radiation will normally stop ovarian function, which for a prepubertal girl will mean that she needs hormones to get her to go through puberty. For a post-pubertal girl will mean the requirement for HRT after her treatment. In terms of radiotherapy, 5 grays given at 6 years will induce menopause at about 28 years of age. 5 grays at 22 years will induce menopause at approximately 37 years of age. Cranial radiotherapy poses a risk to the pituitary function, which of course has a knock-on effect on the ovary independently. And radiotherapy to the uterus, I'm sure we're going to hear about next, but it causes problems with uterine function in subsequent pregnancies. I wanted to mention a little bit about Ovarian Reserve. This very elegant graph by Wallace and Kelsey sets out and basically shows us that no woman is the same. You have approximately 300,000 eggs in each ovary at the time of your birth. Only 12% remain by the age of 30 and only 3% by the age of 40. And if you put an insult like chemotherapy somewhere in the middle of all of this, if a 15-year-old, for example, is diagnosed and they're born with a high ovarian reserve, so they've got a better than average number of eggs, they will survive the insult. It may reduce them down to the lower end, but as long as they have children early enough, they'll probably be okay. If, however, the child the child has a naturally lower AMH, then that will be a sterilizing insult for them. And so there's a lot of work going on to try and identify things that will help us gauge which children have a good ovarian reserve and which do not have a good ovarian reserve before we're counselling children about fertility preservation prior to treatment. And we're doing a lot of work. There is some promising research about AMH. The levels are low in children, but they may be an indicator of some sort. And for men, actually, FSH can be used in childhood. There's some studies ongoing with that. We need to think about preserving testicular tissue or ovarian tissue pre-puberty for these children. Testicular tissue is experimental. It's not. We don't have any children born from testicular tissue transplantation yet, but we do have mammal models. So it's close to becoming, hopefully, a reality and not experimental. Ovarian tissue cryopreservation, as Alex says, we've been doing for about 30 years now, and there's a growing cohort of children born, which I'm sure Isabel will tell us about. So it's a case of, is it experimental or is it clinical practice these days? If someone's having radiotherapy, it's normal practice to move the ovaries out of the field. But there's also the development of proton beam therapy, which is much more focused and causes less damage to adjacent tissues for radiotherapy treatment of solid tumours that may help protect the gonads. And there is the option of interim tissue cryopreservation, although the ideal is, if we're going to cryopreserve tissue, to get in there first before they have any toxic treatments. In the case of hematological malignancies, the patient may have malignant cells in the tissue and carry the risk of transplanting those back if we're using tissue. And so there is an argument that we might have less malignant cells if they have some chemotherapy first. But also in that argument for the hematological malignancies in particular, a child with acute leukemia is usually very unwell, and they quite often have clotting disturbances, making surgery an increased risk. So we don't always consider it safe to go in and remove an ovary in a child with leukemia who is very unwell initially before they have chemotherapy. Post-puberty, for the boys, we can cryopreserve sperm. We can cryopreserve oocytes for anyone who's gone through puberty. In the adolescents, they tend not to do just so well, but we can still do it. Do they have pre-treatment tissue cryopreservation? Again, moving the ovaries is important no matter what age you are. And the ones that have gone through puberty can have the GnRH analogues to help protect the ovaries during their chemotherapy. And of course, there's interim cryopreservation that I've discussed already. Just a little note, the psychology of childhood cancer survivors. There's two very elegant papers that have been published recently looking at the psychology of childhood cancer survivors. These men and women are less likely to marry when they grow up, especially those that were diagnosed at a younger age and those who were diagnosed with CNS tumours. And female survivors, independent of the type of treatment they had or the type of cancer they had, are less likely to achieve a pregnancy, possibly because they decide not to have children. Maybe they're afraid to have children, maybe they haven't managed to form a long-lasting relationship. And again, with the male survivors, from the article published in the British Journal of Cancer in 2016, 30% less likely to have children overall, even if they have sperm stored. So in conclusion, parenthood is being increasingly delayed, families are getting smaller, and acquired causes of infertility increase as we get older and can cause increased problems for people like us trying to help. Cancer incidence is increasing in both children and in adults, but thankfully cancer survival is also improving. Fertility preservation is not required for all cancer patients, but should be considered for all. We're trying, obviously, the oncologists are always working at looking at safer chemotherapy regimes, safer radiotherapy regimes. So those are a very valuable added tool to everything else. But also remember that cancer survivors may feel differently about having children, having survived cancer. Thank you very much.
Thank you very much, Sara.